This conference will now be recorded.
Patient priority, I'm gonna say it's high priority, we're gonna take her since she's completely unresponsive.
Yep.
And
Also, ALS is 75 minutes away. Just so you
how
know.
far is the hospital?
45.
Well, we're just gonna transport her.
That's exactly what I did.
Okay.
We did
Oh,
not.
did
yet.
not check blood
No.
sugar. What's her blood sugar?
Blood sugar was 410.
So maybe not overdose, maybe.
Maybe.
Most likely hope
When you ask the husband,
blood sugar.
if she used anything, he said no. Cops on scene said that both of them are known users. Meth.
Does she have teeth?
She does have teeth. They're not great, but they're there.
All right, well, we're
She's not
transporting.
huge, but not little either.
Can I bring the husband with and keep asking him questions in the ambulance?
If you want. He's pretty unreliable so far.
Well, Narcan's if they're not breathing. If she's
Not
breathing.
necessarily.
Is it?
Yes. If she's over
You still give Narcan if they're breathing?
Yeah, why not?
I thought you're not supposed. What? Right.
Well, you don't even know what her
She's-
O2 sat is.
Oh.
You never checked.
Oh, vital signs. All right. Okay. We're backing up. I assumed that was part of my other ones, but okay.
Nope.
So I'll take her
That's
vitals.
secondary
What are the
survey.
rest of her vitals?
Her
Blood pressure.
yeah, blood pressure is 220 over like 130, I think is what it was.
I know that's not good, but I don't really know what
It's
else.
definitely not good.
Pulse. We said pulse. We said the airway. What's her SpO2?
SpO2 is like 85 on room air.
So we're gonna give her oxygen.
Sure. How much
Um,
oxygen would you like to give?
I don't know. I'm not good with that one. 15.
Sure. That works.
She is breathing, so, but she's unresponsive. I'll probably do the non-rebreather.
Sure. Perfect. I mean, you would have to. In your truck, you're not going to have anything that's going to give 15 liters that's not a non-rebreather.
And then to be 6 on a nasal cannula.
Yeah, I think it's 1 to 6 on a nasal cannula.
Can you give unresponsive nasal cannula, or is it just?
Yeah, why not? She's still breathing.
Okay, I don't know.
Is this a lower amount?
She's
Yeah.
not flailing, I guess. So.
Nope, she's not moving at all.
Do we do the Narcan or no?
We have not. Not yet. Would you like to do
I'm gonna give
Narcan?
her oxygen for a minute,
Okay.
and then I'll do the Narcan, even
Okay.
though she's still breathing, but whatever.
Yeah.
Okay, now what happens?
You tell me. What are you going to do?
Oh, I gave her Narcan.
Did you give her Narcan? You said just a minute ago you weren't going to give her Narcan.
Well, I didn't want to, but now I'm convinced I probably
Okay,
should.
you give her Narcan and nothing happens.
I'm just gonna keep giving her oxygen and keep transporting her.
Okay. How are you going to get her out of the house?
What's the doorway like? Is it gonna be a pain in the ass?
You
to
ain't getting
put
a stretcher in
striker
there. Yeah, you're not getting a stretcher in.
Okay, then I'm gonna put her on a mega mover and
Perfect. That's
Hopefully
exactly
I-
what I did.
got enough hands to carry her.
You have 2 cops to help you.
Cool,
Yeah.
that's great. In the ambulance though, not while we're mega moving. I'm gonna reassess her vitals while we're mega moving her.
Blood pressure is still way high. I think it was like 230 on the second one, 230 over like 130, somewhere in there.
Still?
Yeah.
Or was that the second?
That's the second one. It was
Okay.
still crazy high.
But wouldn't her heart rate increase after?
Not necessarily.
She doesn't have a
Has she
history.
overdose? Cause it?
Not necessarily.
What's her pulse?
Alert.
Second.
She's very unresponsive. Yeah. To pain and verbal and everything.
Oh, okay.
What's her pulse the second time around? Is it still?
It's still,
tachycardic?
yeah, it's still like, I think it was maybe 110, 115, somewhere in there.
Do we give them anything for high blood pressure while we're in transport?
What are you as a basic EMT going to do for high blood pressure?
Nitroglycerin, but I don't know. if
What is
we're
nitroglycerin indicated for?
Typically indicated for heart conditions, but it
Yeah.
also drops the blood pressure.
It can,
Okay.
but would you say that there's an indication?
I
to
don't
give
really
this?
care that I don't
Does your
think I need
patient-
to dose her with
Yeah,
it.
does your patient complain of chest pain?
No, she's unconscious.
Exactly, so I would not give.
Okay.
I wouldn't. That's just me.
So then I'm just gonna keep her on oxygen.
Okay, oxygen sat looks okay-ish, 92 to 94, somewhere in there.
So it's going up because it was like
Yeah.
88.
Yeah.
And I'm just gonna take her to the hospital.
Can you do another
And I'm gonna
dose?
keep assessing
can.
every 5 minutes because she's unresponsive.
So what do you think right now is potentially going on with your patient?
I have no idea.
Okay,
You
we'll say,
I
because
know
typically most
her
people are not gonna,
symptoms.
most
her
people are not gonna like
signs.
reassess eyeballs. I reassess her eyeballs. One was about 1 millimeter, the other one was about 2 millimeters. users. So they're a little unequal. But on your initial one in the house, they both looked pinpoint.
Are we thinking like a stroke?
Possibly.
Okay.
What would be a clinical indication of a stroke?
Well, she's unresponsive, so I can't do fast on her very well.
Okay.
But is her face drooping at all?
Does it droop when they're
Yeah,
unconscious?
would you still get facial droop with the unresponsive?
I
Um,
think so, because it's
So I think I've only seen a facial droop in an ischemic.
No, so the hemorrhagic stroke that we had 2 weeks ago, he had a facial droop, and he was not unresponsive, but he was pretty out of it.
Yeah. I don't think I've ever seen facial droop with a hemorrhagic.
my
I've only
grandpa
seen-
had a stroke.
Yeah.
A lot of when I was a baby, and he still had like facial droop while he was asleep.
Yeah, which I mean is very possible.
There.
This lady did not have any facial droop.
Okay, because I mean paralysis is still there when you're unconscious.
Yeah.
What am I missing? Blood sugar. Did we?
It was
I thought
like
we
four. It was
tested-
like
yeah,
410.
We tested the
Yeah.
blood sugar.
Yeah,
So
it
she's
was
got
like
high
410.
blood sugar. That's right. So we're not necessarily thinking she could be a blood sugar induced stroke potentially, but I don't
What-
think so.
What is the thing that happens when you have really high blood sugar?
Ketoacidosis,
That's it.
DKA.
So she could be in a diabetic coma.
So we're just gonna fly to the hospital as fast as we can.
Okay.
Because ALS is twice as far out as we are from the hospital.
Okay. What if you had a partner of a higher level, what would you do?
I'd be like,
No.
there you go.
If
Help me
you're,
out.
what things would you, what interventions would you want done for this patient?
Yes, IV. And
Her arms are trashed.
well, because she's a junkie.
You gotta do that.
Fetal.
I mean,
What's super easy to do on pretty much anybody?
Oh,
I fucking IO'd her in the leg
ew.
oh yeah.
Okay.
because she's unresponsive.
Yeah.
And then when I IO'd her in the leg, she actually had a pain response to that.
Oh.
So
Well, that's a good sign.
yeah, it was a decent sign.
What did you give her in the IO?
I gave her a liter of fluids because she had a blood sugar over 300. So I pressure
that-
bagged a liter of fluids into her.
All we would do in the field on the way to the hospital for
Yeah,
that?
so DKA, like high blood sugar, the only reason why you administer fluids for high blood sugar is for the dehydration issue,
Right.
because the overloading of fluids is actually gonna help their sugar.
And it would just
They
be
need it.
DNS, right? The
Or
normal cycle.
LR.
Oh,
All I had was NS, so that's what she got.
I like LR just because of hemodynamically, it's got a better,
It's the
it's
Gator.
got a little bit more
What's
stuff in it
NSNLR
that.
stand for?
Normal saline.
normal saline.
Yeah, normal saline is like salt water.
Yeah.
LR is lactated ringers or ringers lactate.
And normal saline has a pH of like
5.5, I think.
Yeah,
I
something
think
like
it's
that.
5.5.
And then like LR has a pH.
I think
of
that
like
one's like 6.5.
6, yeah, or
Somewhere in
like
there.
6.3, 6,000.
Yeah.
It's like water versus Gatorade.
Yeah, LR is like the Gatorade of fluids. That's how I remember it.
I thought on Tuesday we said that there's not much that we can do for DKA. That we just get them to the hospital as soon as
Yep,
possible.
Yeah.
because they need
Give 'em
insulin.
Fluid.
Yeah, you can give them fluid for the dehydration stuff, and that's all that's gonna help.
Yeah.
Okay.
So differential diagnosis, what do you got?
We're just treating her signs, and so her blood pressure is high. We're not gonna be giving nitroglycerin. That's a bad idea, potentially. We are giving her oxygen to keep her O2 up. We're transporting her as fast as we can to the hospital when she's got the IO
Yep.
on fluids.
About a 12 lead.
We
Do you want
put
to
a
get 12
diaper on
lead?
if she decides to piss all over the place.
No.
Just kidding.
I mean, you could. She was very naked, so
We got blankets.
I would do a 12 lead.
A
I
12.
did do a 12 lead.
Okay.
Yeah.
And so, I don't know what am I missing.
Different.
Yeah. What's your differential? Like what things could it be?
Okay, I'm thinking DKA, potentially stroke, but the blood sugar is kind of the biggest indicator. And we didn't see any other signs of stroke, it's just the unconsciousness.
Yeah.
So,
Sepsis.
what was her blood pressure?
Blood
I-
pressure was like
One-
230 over
Yeah.
130.
So
Somewhere
that's a good indication for a stroke too, right?
especially with the unequal pupils.
unequal
So
pupils.
unequal pupils, hypertensive, and remember what Calvin said with blood sugar, when you have dying cells, your blood sugar goes up with it. So if they're having like a hemorrhagic stroke, that's gonna like make your pupils unequal, but it can also raise your blood sugar. Is it gonna make it 400? Like probably not.
Yeah.
If her sugar was sitting there like in the 300s, would it jack it up to 400? Like probably, because those cells are dying and releasing all that glucose, and it's gonna jack your sugar up.
Is it possible then that it's both, like a
be.
stroke-induced DKA?
Yeah, because
or-
we had one like a year ago that was having a stroke and a heart attack. We could assess the heart attack because we could see it on the 12 lead, but we couldn't assess the stroke because she had a GCS of 3.
And is that why you did the 12 lead?
Yeah.
It's to see.
Well, then like our particular guidelines say that anybody over 20 that has a syncopal episode gets a 12 lead.
Anytime you have somebody with a single episode, even
Yeah.
if they're under 20, should have a 12 lead.
Yeah.
Here's the trick of the trick. Anybody that checks off the AEIOU tips, right, altered mental status, anytime that you have syncope, you should also be thinking AEIOU tips. Anytime you have somebody that has near syncope, dizziness, anything like that, run AEIOU tips through your head and check off all of them.
12 leads should be on that list. Yeah, you can't read 12 leads.
But you
But-
can transmit it to
But
the
we
hospital.
text
You
it to
can.
you, Lynn.
Yeah.
Yeah, you can send it to us, right? Like I don't mind
So
because like our monitors can't transmit 12 leads, right?
send these
So,
guys 12 lead. Literally yesterday I sent them a 12 lead
Yeah.
because I was like, I don't know what this is.
So like our phone, we get them all the time.
Yeah.
We always get 12 leads
Yeah.
from folks where they're like, what the frick?
Yeah.
And
So-
then I'm like, Becca, somebody text you.
So this lady was having a massive hemorrhagic stroke. When we got to the hospital, they sent her over to CT. She had a huge bleed on I think it was the right side of her head. And the only thing that they did that I could not do was they put her on 3% normal saline, which we don't carry. They gave her mannitol to help bring down the intracranial pressure, and then they intubated her. But they wanted to wait to intubate her until they verified that she was having a stroke and it wasn't a diabetic coma.
So what were the big signs for hemorrhagic stroke?
Unequal pupils, crazy high blood pressure,
Is
unresponsive.
that all stroke or just hemorrhagic?
Mainly it's just hemorrhagic. With
Yeah.
the TIAs, you can have like the Cincinnati positive Strosco, or you get like the deficit on one side. Their blood pressure may go up a little bit. But like, so when you have those hemorrhagic strokes, you have such a buildup of pressure in your head. That's what's causing your blood pressure to build up because your heart's trying to pump against that pressure in your head to compensate. And so you get that giant jump in blood pressure. Where with just like a TIA or an ischemic stroke, your heart's not working as hard to try to pump around it because it's still going in your head and it's still like pushing around in other vessels. So you'll have a raise in blood pressure, but you won't have like that giant jump. When you have hemorrhagic strokes, you'll see pressures 230 over 150. You'll see pressures like way through the roof. Most of the time they're going to be unresponsive, and they're going to have like some form of like unequal pupils. They'll have like a gate, like with their eyes. Whenever you pop their eyes open, they'll look up and to one side or the other, depending on what side the stroke's on. So like the one we recently had, when I popped his eyes open, he looked up and to the right. So they look towards the injured side. So that'll be another big thing that you see. And then with the hemorrhagic strokes, a lot of times you'll see like their heart rate will start dropping, their respiratory rate will start getting all over the place. So they'll have that.
Do you
Not
think
the
any
Kuzma, what's
patients
the other one?
go unconscious?
that?
often?
The
Yeah,
respirations, not the Kuzma, what's the other one?
Oh, Shane Stokes.
Shane stuff.
Yeah.
Jesus Christ.
So like I had a lot of time to like trend this patient. So like he just said like her heart rate was at like 100 and it dropped down to about 50. And I was like, I'm slapping some pads on this lady. So I put, pads on her just because she was like trending downwards. As soon as I put the pads on her, it went back up. So it was
Did
just,
you Narcan her?
I did Narcan her. Yeah, that was the first thing I did. Because when I first looked, like it's when you're in the house and like it's not great environment, like when you look 1 millimeter versus 2 millimeters, sometimes it's kind of hard to identify.
Right.
And then when I looked at her again after I got a really good blood pressure and all that stuff, and I saw her blood pressure was crazy high, I was like, I'm gonna look at her eyes again. And then when I looked again, that's when I like really was able to notice, because we were in the ambulance, like I was in my environment, and I had my checklist that I was going off. Okay, I need to do this, 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 and this. and I did all the things. And of course, like I had a 45-minute transfer to do all those things.
So did you bring her here or did you?
No, I was in Wells and I brought her to NMRH
Where's that?
Well,
in Elko.
in Elko.
Yeah.
The hospital in
Oh,
Elko.
it's the hospital. So if you were here with a 45, you said you were 45 minutes, but this is an hour and a half from, we wouldn't even go to Elko for hemorrhagic, right? It would be Utah. So you would just ask for ALS
Utah.
intercept, or would you just bring her here and then?
So
We
the
are
best
ALS
thing
here.
that you could do for her is think about where she's at, right? So
Yeah.
your number one is ALS intercept. So like a week ago, I don't know who was riding. I think it was her. Were you riding with Calvin and Marcus?
Mhm.
So
Yeah.
Calvin and Marcus are both EMTs, right? So they were riding as a double EMT truck. Me and Becca had one of the response vehicles, so if anything hit the fan, like we could come. But at 2 o'clock in the morning, it might take us a second to get there, right? So at that point, the best thing you can do is call for flight, call a doctor, and figure out what he wants, right? Because at that point, like, yeah, your ALS intercept may be an hour out, but if you can call for a flight, maybe they're 45 minutes away or an hour. Maybe you get lucky and they happen to be flying back to town and they're over top of you and they can just drop on top of you. So really just depends, but it's always better to start that and then not need it. I have started helicopters out here numerous times and then turned them around. Oh, you gotta start cooking.
Oh, yeah, sorry. I'll shut
It's
up.
all right.
So did you call for?
I called for ALS, but they were 75 minutes away. And realistically, by the time I got to Elko, I didn't think that there was anything that they were going to do different than what I already did, except for maybe intubator. But then when I got to the hospital, Dr. Milligan, she was like, I would not have intubated this person until I knew for sure that it was a stroke versus DKA.
Because
So-
DKA, you have to be really careful about intubating those people because if you don't compensate with them, then you're gonna kill them.
Oh, right.
Higher respiration.
I think it's a
But her
key thing to,
respirations
like-
were normal, right?
Right.
What's that?
Her respirations were pretty
Yeah, they were
regular.
pretty normal. I think they might have been a little fast. I don't remember. But they weren't terrible. But she was still breathing. She wasn't necessarily protecting her airway, but she was maintaining it. If she had thrown up or something crazy, then yeah, for sure, I'd have been like, hey, we need the ALS intercept.
I think the big thing too is like the officer on scene told him right away, like, oh yeah, she's not a drug user. So that's really easy to kind of get stuck down that rabbit hole. Like,
Yeah.
oh yeah, she does drugs. That's all this problem
Yeah.
is. But you gotta remember, doing drugs like meth puts you at a higher risk of things like a stroke. So remember those things when you go assessing.
Yeah. And the guy that was there was like, oh, we've been sober. And I was like, for how long? He was like, 2 days. And I was like, that's not sobriety. You just ran out.
So keep that in mind, right? Like, I've been there before too, where especially when I was like really new, a newer provider, I gave a guy Narcan that I was like convinced. I was like, this Narcan is gonna work. He ended up breaking his neck and he had a simple episode, fell over as he was getting up off the couch. Very small fall, wasn't far at all. And I was convinced that the Narcan was going to fix him. I hammered him with Narcan. He was still breathing on his own, but I gave him with Narcan and couldn't find out. He snapped the piss out of his neck and was paralyzed from about mid-sternum down. So
Is there a time where Narcan can be harmful? Because he says not really.
Such a safe drug.
it is a safe drug. The biggest thing is if you're going to give Narcan, what do we do?
First.
Always oxygenate them first. So if you do not have a pulse ox on them and you do not know what their oxygen is, do not give them Narcan. Because if their oxygen is freaking 60 and you hit them with Narcan, when they wake up, their oxygen is still going to be 60 and they are about to fight the piss out of you and puke everywhere. And possibly the only side of, I won't even call it a side effect, the only adverse reaction that people have gotten out of Narcan is flash pulmonary edema. Do you know what they've traced flash pulmonary edema with Narcan used to? Low oxygen levels. So people that come back after they are severely hypoxic and get slammed with a bunch of Narcan could potentially have flash pulmonary edema, fill up with fluids, and start drowning. So oxygenate these people prior to Narcan with these people. Outside of that, it's pretty benign. There's not really I mean, that's the same thing, right? Like I had a guy out here wrecked his motorcycle, had a fat head injury, freaking ended up having a massive head bleed. And I called Becca and I was like, I might be missing something here. And because me and Becca, every once in a while, we'll just call each other and like talk our way through a call. And I'm like on the phone with her, like doing stuff with this guy. And I'm like, I might be missing something here. Like maybe he's overdosing. I was like, I don't know. And she's like, what, did you try Narcan? I was like, not really, because like I'm probably going to intubate him. And if I give him Narcan, then my medicine that I use for intubation ain't going to work anymore because we use fentanyl for pain management secondary to intubation. Now it's not going to work anymore. So I don't really want to do that. And I don't really think it's an overdose, but it could be an overdose. I really think that it's maybe a head injury because he's got all the signs, but like there's a very minor accident, so that don't really make any sense. It ended up being a massive head injury, and I ended up intubating. So
Is there like a correlation with DKA and needing to use the restroom? Because like one of my best friends, well back, she had DKA, and that's where they found hers in the bathroom.
Yep, there is a correlation because you get that polyuria, where you have to pee a lot. So a lot of people have to pee a lot. You start peeing a whole bunch, and that's kind of like a clue. Like if you're like ever have any issues where you're like thirsty all the time, you're freaking peeing all the time, especially at night, stuff like that, you might want to go get your A1C checked.
Your report, when you filled out that you administered Narcan after everything, did you give your signs and symptoms, like when you wrote that, where you like pinpoint people's later reassessed and they were actually different?
Yeah. And you're not going to get knocked for it, right? Like if you can justify why you did something. Now if you're just out there like, oh, this guy, like that video I showed y'all, this guy's running around like, frick y'all, I don't want this. And the guy's like, you're going to take the Narcan. Like at that point, it's not justification, but unresponsive.
There's some people that just walk around with unequal people. It's the thing. The anisacoridia, right? Like, it's just the thing. Like, my old fire chief in Lovelock has it. And he just has unequal people all the time. But her being unresponsive, and the cop said, I said, hey, did she take anything to the guy? And the cop was like, she's a known user. I said, okay, cool. So I hit her with Narcan real fast, and then went on from there. And like I said, when I got into the ambulance, I was like, let me like really, really assess this person. Because initially it was like, okay, we just gotta go. Right? Flight's 75 minutes away, which is ridiculous. And we're bombing out here. And then stepped into the office, right, and did all the things.
Cool. All right, let's get this party started.
All right, so we'll try and get through both of these chapters tonight. We're kind of low on time. So if we don't get through them both, I'm not gonna keep you all till 9 o'clock. So it'll be nice.
Maybe 8.
Maybe 8:45.
Hey, I just gotta go to work after this. You can keep me as long as you want.
All right, so allergic reactions. Our objectives, we're gonna look at the pathophysiology of an allergic reaction. What kind of shock does an allergic reaction cause? Anaphylaxis, right. So define anaphylaxis and determine what is considered an anaphylactic reaction, and then we're gonna review our dose of epinephrine. So I got good news for y'all. For the state and their list of meds that you can give in the state of Nevada, with proper training, if you work here, you don't have to, it doesn't have to be their EpiPen, and it doesn't have to be their inhaler. We're gonna get more clarification. I talked to Mikey some today. If that's the case, we're gonna teach you guys how to do nebs. We're gonna teach you how to do the epi. It doesn't have to be the patient's epi. That makes sense. So that might be coming, that change might be coming. So I'm very excited. So we'll talk about
Very
it.
excited. Very excited.
Very excited.
And just as a clarification, right, because anaphylactic shock falls under one of the 4 umbrellas, right?
Uh-huh.
So that would be obstructive.
Not quite. So everything expands. So it's gonna be what kind of shock if all of your vessels expand. If it's a vessel problem.
Starts with a D.
Distributed.
Distributed.
Because it is a systemic issue.
Obstructive is like your PEs, like if you have a tamponade, that kind of stuff, anything
It's
obstructed.
obstructing blood.
Right, your heart's like obstructed or the blood flow's obstructed, it can't get past a certain point. This is like everything just goes through and then obviously it's not gonna keep tone. So, all right, so we're gonna review the dose of epi. Again, that might be changing. So just, we'll let you all know.
The dose or the administration?
All of it.
Okay.
All of it.
Because the dose changes whenever you can self-administer and you're not using the EpiPen.
Okay.
Oh, gosh.
Yeah,
Yeah,
it should be
you
in all
poured it.
y'all's papers. It's the dose in there anyway. The dose is the same in an EpiPen that you're gonna give if you draw it up. All right, so immune system, it responds to foreign bodies in the airway or foreign substances in the airway. I told you my brain cells are gone today. I just hear foreign body and I'm like airway. So it responds to foreign substances in the immune system, and then it kind of attacks that substance. But the problem is sometimes it kind of overdoes it. That's where we get our allergic reaction. So an allergen is the substance that causes the reaction. So whether that's peanuts, whether that's bees, whether that's flowers outside, even allergies like throughout springtime, summer, or whatever, that's all caused, that's a substance, right? An allergen. And then your reaction is an exaggerated immune response. Oh, you stole my standing spot. I don't know where to go. Yep, yeah, sorry. I get too excited and I quit. I really don't know where to stand. This is awkward. I'll stand next to you.
Peanut.
Peanut. Cool. Peanut.
He's a pretty good job. He's a pretty good streamer. He's also very good boiled.
Who here's allergic to peanuts? Is it Harlan?
Huh?
Harlan? Is he allergic to peanuts?
Asian boiled.
Someone
Marlon's
says
allergic
allergic.
to cinnamon and
Coconut or something?
coconut.
Oh, coconut, that was
I
it.
thought pineapple was the same, but that picture is okay.
Yeah, what was the pineapple picture?
Safe word. That's safe word.
Oh, I got you, okay.
We were so.
I was like, yeah, I was so confused.
I
It
would
doesn't
say
help
that.
us.
It's safe word. I don't know if I love pineapple. Like, Steve, what are you doing?
Oh, dude, pineapple's such a lame state
I feel like Squidward. It's over.
It's gotta be like onomatopoeia.
word. Or like
Yeah.
fucking huckleberry, something that takes
Yeah.
a little longer than pineapple. What the fuck?
Ours is pickles for food, so.
Oh, yeah. Let's go.
All right, so initial exposure, that allergic reaction does not occur, the big, scary, exaggerated immune response, that doesn't occur the first time you come in contact with that allergen. That's something they need to be exposed to first. Their little cells are like, hey, this guy's bad. And then next time it sees it, it's like, throws everything at it. So the initial exposure doesn't cause it, but the immune system forms those little antibodies. Then it sees it again and it's like, all right, this is time to go out. And so then everything just releases. There's a huge release of histamines. And then you can have a whole bunch of different kinds of reactions. So when you think anaphylaxis initially, you're like, okay, airway swelling, wheezing, hives, that kind of stuff. But do know that it can cause other things. It causes low blood pressure, right? It can cause like vomiting, diarrhea, headaches, dizziness. All of that stuff can be caused by an allergen. Yes.
Anaphylaxis is always the one that affects two systems, right?
Yes. Or just the airway. So any two systems or airway. So if there's any kind of airway involvement, your lips do not count as airway involvement. You can have really swollen lips and still be moving air just fine. As soon as there's like past the point of your lips, your tongue, your uvula, your airway up here, wheezing, that is anaphylaxis. But yes, very good. Very good.
We never said really do that stuff by me. I was thinking of it was funny.
That happened to my mom who was inside her soda can.
Oh no. I would die.
Literally.
I literally would die.
No, it was, but her lips swelled up.
Jeez.
That's the only time I ever been stuck.
Was it in a soda can too?
No, I opened my mouth and it was there.
What?
It was really weird tasting after that.
Yeah. Yep. All right. Y'all good?
Yep.
Okay, so here's our stages, right? So initial exposure, our body produces antibodies, and then they re-expose those mast cells, release histamine. That histamine is like a systemic problem usually, or it could be localized. So like if you just have, your eyes are swollen shut, or you just have hives, that's like localized. Then this can happen hours later. So inflammatory cells, then they sustain their inflammation, and then your anaphylaxis. So as soon as 2 or more body systems are involved, or just your airway, it is now considered anaphylaxis. So they need that first initial exposure to go into anaphylaxis. So like for me, I was stung by a bee. I've been stung by lots of bees when I was a child, and then I turned 20, got stung on the foot. I was covered in hives. I had wheezing, and I earned myself a trip to the ER. But all of the other times that I've been stung, I've never had that kind of reaction. So no bees. Unfortunately.
You just wear a special suit.
Huh?
You just wear a special suit.
I'll wear a special bee suit.
Oh, I thought you were talking about like one of those things like albino people wear.
Albino?
I just know albino people wore a special suit.
Yeah, the guys from California, and I was like, why are you wearing that? I don't mind. I was like, bullshit. You pull his little thing off, and it was like, oh, super white. His eyes were red, but it was like
this
super white.
is kind of a killer, Bella.
Like this protects me from the rays. I was like, okay, cool.
All right, so anaphylaxis is a distributive shock, like you said. So what that means is that blood is having a hard time getting everywhere it needs to go because all of your vessels just relax. They lose tone, loss of tone. So those blood vessels dilate rapidly. There's usually a drop in blood pressure. If you ever have like a patient that is like low blood pressure for an unknown reason, and you're like running through everything like, okay, they've been hydrated, they have this and that, always suspect some kind of anaphylaxis. So I didn't run this call. I heard it from somebody, so it wasn't me. But they had a patient. He was covered in blood in the bathroom, just absolutely covered in blood. They get there, his blood pressure is low. He's altered. He's trying to fight them. He had gotten stung by a bunch of bees, went into anaphylaxis, was freaking out, running into the bathroom, like beating his freaking head and stuff over everything, got all bloody. So they walked in, they thought it was purely trauma, but this guy's in anaphylaxis. So it's always one of those things that need to live in the back of your mind, like, could this be anaphylaxis? You should ask yourself that on a lot of calls. So that fluid goes into the interstitial space. So outside, that's where we get like our swelling. We get like the swelling on our face, swelling in our airway, all of that fluid's just in the wrong spot. Ooh. So I feel like epi, if you're ever like dealing with any kind of allergic reaction, you're not wrong to give epi. If you're like, hey, I need to give epi, you're not wrong in doing that, but just know that there's like a certain threshold in which you should give it. But if you're like, hey, I was kind of concerned, so I gave epi, even though it didn't have 2 body systems, nobody's going to flack you for that, right? So it's okay. Epi is going to be what saves their life. So if they did need epi, awesome. You just saved their life. And if they didn't need epi, they're a little bit anxious and their heart rate's a little bit faster for a little bit. So it's one of those drugs that's like, we don't over give it, but if you do give it, it's not going to cause that much of a problem. Okay, so airway involvement, wheezing, tongue edema, stridor, that little uvula being swollen in the back of the throat. What's stridor? What does it sound like? I just didn't want to do it. Y'all got it? Good job. So, or signs and symptoms of shock, and or 2 or more body systems involved. So if you have signs and symptoms of shock, which is what?
No, SPO.
Low SpO2.
Increased
What
heart
else?
rate.
Huh?
Increased heart rate.
Increased heart rate. What else? Cold? Pale? Low blood pressure? Pallor? Like that paleness that they get? So, yeah, they get that feeling of impending doom for sure. I wouldn't say like, I I would associate that with other signs to be like, okay, now you're in shock. I wouldn't be like somebody just having the feeling of impending doom, putting them in shock, or like saying that that is they're in shock because of that. They would have to have something else. But yes, that can be a sign of shock. So, or 2 or more body systems involved. So, what's integumentary? Good. What's this?
Your favorite.
My favorite. Calvin's favorite.
Brain.
Yeah. So vomiting and low blood pressure after eating peanut butter would be considered anaphylaxis. There's no skin signs. There's no wheezing. There's none of everything that you'd be like, that's anaphylaxis. But
Charcoal. If somebody eats something that they're not supposed to.
not quite, because peanut butter is like, doesn't have the surface area for it, right? So you're talking about like covering pills. So like usually your dose of activated charcoal is given within 30 minutes because you want to give it before that pill starts to get digested. Once that pill is like apart and digested and broken up, that's not going to work as well. It's a good thought, but I mean it might work a little tiny bit, but
What pill?
activated charcoal.
Oh.
Yeah, so it tries to cover pills. That's the thought behind it. Oh yeah, sorry.
You're good.
Okay. You guys pull the PowerPoint up on your computer so you can see right in front of you. That's so smart. That's
Right, it's
awesome.
not as,
Yours is way broken down compared to what is given to us on the PowerPoints, but
Oh, is it?
you like pull a lot of the stuff out of it, so it kind of not dumbs it down, but you pull the important stuff, and this is like right there.
Oh,
So,
that's cool. Yeah, I thought y'all were pulling up like the meeting and had it on there. That's smart though. That's very smart.
just going into the,
Yeah,
Yeah.
so you don't have to be like. So here's our systems, right? So whenever we assess anything, it's important to check at least 5 or try to go 3 to 5 systems on your secondary assessment. This could be a good reason why, right? So you can have skin involvement, that would be your integumentary, so hives, swelling, itching, warmth, redness. You can have like wheals, they're called wheals, which is just like raised bumps of hives. It's just like in a circular pattern on your skin. Your respiratory, obviously anything involving your airway. So cough, shortness of breath, wheezing, swelling in the airway, swelling in the throat, stridor. GI, nausea, stomach pain, cramps, vomiting, diarrhea. My brother, if he freaking eats any kind of bell pepper, he just starts getting like the worst stomach cramps he's ever had in his life. So he's allergic to them. Cardiovascular. So dizziness and lightheadedness can be caused from like a low blood pressure, right? So also fun fact, anaphylaxis can mimic a STEMI on a 12 lead. So you still treat it with epi and all that, but if someone's having an allergic reaction and you're doing a 12 lead and someone's like, that's a STEMI, it can mimic that. There's like a spasm that happens. So that's super fun. There's a name for it and I can't think of the name.
for what?
The anaphylaxis-induced heart attack, the MI.
It's the
I'll look it up.
Sweetostem.
And then neurological, so that feeling of impending doom that you were talking about, headaches, all of that. And you. So I think that they're throwing it in here because of the low blood pressure thing is a cardiovascular problem, and that can cause your dizziness or like. But yeah, I would also think that's a neurological.
Why would uterine cramps not be included in GI?
So your uterine, like your reproductive system, is its own system. Whenever we're breaking them down, so GI is like your belly, your intestines, all that. This would be like a reproductive. That's a whole nother section.
And is it strictly for females, like the uterus? Or
I-
is that?
I'm guessing.
Uterine
I don't know. I've
system?
never seen any kind of like uterine cramps when it comes to like an allergic reaction, and I almost wonder like what causes it. But I'll have to do more research on it. I need to make a list on things I need to look up today.
That's a good question, because I'm not even have a board right behind you. They start writing things on.
Yeah, you're right.
I have a marker in my hand. What do I do? Okay,
Just
so-
saying.
What was the one that Shia said Tuesday?
What did Shia say?
You asked a question and Rebecca was like, I don't know, I should look that up.
Oh, I don't remember.
It's a good one.
Okay. Okay. Very good. I'm gonna keep this in my hand. All right, so signs and symptoms, your dilation of blood vessels. This reduces the amount of blood that is able to be returned to your heart. What happens is everything that had tone at one point now relaxes, and so it has a hard time getting back up to the heart where it needs to go. That causes low blood pressure, right? You can have flushing of the skin, so these blood vessels near the top of the skin also open up, and that can cause like that flushing around the face, neck, chest, belly. And then angioedema is that fancy term for facial swelling. So that fluid goes into those tissues and it causes swelling.
What did you touch? I don't know, I can't see.
I can't see. Call 911.
Angio, short for face.
Face. So facial swelling, edema, and swelling. So another thing that can cause angioedema, and you might see it on a test, you might not. It's important to know working. So you can have something called ACE inhibitor-induced angioedema. So what that is there's certain types of medication, like lisinopril is an ACE inhibitor. That's just the type of medication it is. So you can have a patient that's been taking lisinopril days, years, but all of a sudden they get like swelling in their face and neck. And it's very scary because there's not a lot we can do for it. You can try and treat it like a regular allergic reaction, but it doesn't work. So they treat it with PXA or fresh frozen plasma. But that's one thing to kind of know if you're ever seeing like angioedema, check their med list. So if they're on any kind of lisinopril, what's the other ACE inhibitor? Lisinopril is the only one I can think of at the moment.
That's the one that causes a cough in some patients.
Yeah, some people get that like chronic cough with lisinopril. It just doesn't go away until they get off of it. So it's a blood pressure medicine, but it can cause angioedema. So like I had a patient with Mikey. We walked in and he had stridor, and like clearly there was something going on upper airway. Found out he had a tumor in his airway that had started swelling. He waited a few days to call us, but whenever we got there, he's on lisinopril. I'm like, is this an allergic reaction? This is stridor. So like, it's clearly an airway problem, but like what kind of airway problem? Like, how do I treat this? So I threw everything at him because I was like, oh, here's an albuterol treatment. It's because you're not moving a lot of air down here. Here is TXA in case it's ACE inhibitor-induced angioedema. Gave him steroids to help move that swelling out of his airway. And I was terrified the whole time. I was like, I don't know. Like,
Did you get a relief from any of that?
Yeah, so odd because we got on scene. He's like stridor, came out as difficulty breathing. 5 o'clock in the morning. Of course, I dumped my med box on the floor and it broke open and everything went everywhere. So that was just like one of those days, Called the doctor, was like, hey, this guy has stridor. Like, at what point do I pull the trigger to intubate him? Like, when do I take his airway? Doc's like, I don't know, fly him out. I said, okay. Gave him the stuff while we're on our way to the airport. The airplane was 45 minutes out. This guy's breathing like, hee. And as soon as the airplane landed, Mikey stepped out to go talk to them. And this guy goes, I feel better. And like starts talking to me normal. And I'm like, wow, what did I do? So after further research, the Solumedrol is what they give for swelling in the airway. And Solumedrol takes about 45 minutes to work. So that Solumedrol finally kicked in and released everything. But I was, no, it was bad. So, yeah, it made me look like a liar because we're like, he's got stridor, we're going to have to take his airway. And the flight crew just steps up and he's like, hi guys, how's it going? Huh? Yeah, we still flew him out to his cancer center in Utah. It was very interesting. Very interesting. Okay, and then swelling around the vocal cords, your hoarse voice, your stridor, your upper airway stuff. These are all things that you're going to see. Oh my gosh, I thought, did I not click this and I went to the next one? Oh, I'm just losing it. Sorry, y'all. So urticaria, fancy name for hives on the skin. So anytime you see hives, that differs from flushing because urticaria is usually raised up, whereas flushing is just redness. Urticaria, the hives are raised bumps. Bronchoconstriction, so that's what you're hearing whenever you hear wheezing. And then you can have that thick mucus in the lungs. If there's any kind of fluid shift, it can go into the lungs as well. So you might hear rhonchi. So rhonchi, remember, is rhonchi in the bronchi. It's a little bit higher up. It's like that bubbly sound. They're trying to breathe through mucus.
What's her name in the nurse? She's the one with the cool stethoscope. Not Mary. Is it Mary?
Crystal? There's Crystal, Mary.
I think it is Mary. She's like yay high, blonde hair.
That's my Mary.
Yeah, she let me use her stethoscope for really cool one.
That's cool, huh?
And I thought I heard some wrong. It's like the bubbling kind of, right?
Yeah, so it's like thicker bubbly is the way I would describe it. Like rhonchi is like, whereas, so crackles is that one. That's crackles.
Oh, those
rails.
crackles.
So the little tiny bubbles is crackles, rails, and then bronchi is like bubbly. Oh, sorry.
How does like big rub work when you're breathing it in? Is that, what is that doing in your airway? That makes it help. Like, when you're sick and then you put it on your nose, like on your chest.
Yeah, you know, I don't.
Is it like kind of working like albuterol?
I
Like,
don't
or
think it
opening
would
up,
work like albuterol.
Or is it like reducing swelling in your sinuses?
Or is it
Maybe because it's cooling, you know?
Right.
There's another thing.
But is it like
This-
sticking your head in the freezer? Like it's not really helping, you just think it's helping?
Maybe. But like someone with croup, like a kiddo with croup, cold air like really does help them.
The book didn't say that though. I know that, but I was a little bummed when the book didn't say that.
I know.
Really fine children.
My
I
list
did
is
find out, sorry, I did find out what the Q is for beef, why they use a Q. It's quality. It comes from like a Latin root, like what was it, quantity, so quantity, like the amount of blood circulation. So it's a Latin rooted quantity, and then they just cut to the Q when they went to English or something like that.
That's rude of them. That's interesting though.
Q for
I didn't know
quantity
that.
of blood.
Yeah, that is interesting. All right, so substances that may cause, obviously insect stings, any kind of insect, not just bees, plants, food, medications, shellfish, certain kinds of meat. So you can have a histamine release with any of these things and more. Latex, very common. Again, it's like that multiple exposures to it, and then you'll start to develop an allergy, kind of like gel nail polish, or like if you get your eyelashes done, you can develop an allergy to that glue. So same kind of thing, just multiple exposures to one thing. 98% of the gloves that you find in EMS are going to be nitrile gloves, or they don't use latex gloves anymore because of this. You'll have patients that are allergic to latex and be concerned about the gloves. Most of our gloves are nitrile. So if you're using latex gloves, you'll know they're stretchy. They got like that sound to them. I hate it. So nitrile gloves, lunch lady gloves, some kind of thing. You can have somebody that's allergic to this though too. And the powder that comes on in the inside of some of these gloves, they can still be allergic from that.
What if you're allergic to both?
So I worked with a guy in Idaho that was allergic to nitrile and latex, and he would buy bulk lunch lady gloves, like those little cheap plastic ones, and he would use those if he needed it. But most of the time, he just didn't wear gloves. Yeah, the little cheap plastic ones, they work for him.
Did you do that and then put one of those?
Yeah, yeah, he put it on and then put like the glove over his hand. Sorry, I should have clarified that.
I was like,
He wasn't walking around.
Plastic gloves.
Like, yeah, yeah, it was like a condom for his like nitro or his nitro.
That's awesome.
Yeah.
They also have different brands too. So some of them don't use like powder.
Oh, yeah, yeah. I wonder if we can figure that out, because I was looking on our box when we were like, it's supposed to make my hand itchy. It doesn't say anything.
Yeah, it's like
How would you
hit or
be
miss,
allergic to
right?
Velcro?
Yeah, there's a lady that says she's allergic to Velcro, and I was like,
Girl,
I
That's
think
a
she's
question.
just a little.
girl,
Maybe it just like
It's
irritates
your
her
allergic
skin,
face.
but I would
Yeah.
say it's.
Yeah, like if you rub Velcro on your skin, it sucks, right? But like it's plastic. Is she allergic to plastic?
Yeah, I don't know. It was at our MSHA training, and this lady, she said like twice, and I looked at her like, "Are you all right?
no,
Like mentally?"
no.
Doesn't sound
The
like it.
answer is no.
Interesting. All right, so the exact course is unpredictable. Anaphylaxis is one of those things that can be a sudden onset or it can take hours to develop. Like for me, I got stung on the foot. I said, ow, this hurts. My foot started swelling up. I started drinking Benadryl because I had liquid Benadryl in my house. And 4 hours later, I was covered in hives. So was the Benadryl that I was drinking kind of prolonging the inevitable? Don't know. But again, it can take a while for it to progress. A mild allergic reaction can progress to like severe anaphylaxis. Remember that your epi's half-life is only 3 to 5 minutes. So there is a chance that once you give one epi, you're going to have to give another one if that doesn't stop like or slow down their histamine release. In all reality, you should be, if you have an EpiPen or you're prescribed an EpiPen, you should be carrying Benadryl with it. Because that Benadryl is the antihistamine, the epi is going to stop the severe anaphylaxis, but that Benadryl is going to stop that massive release of histamines. I don't know why y'all can't just give both of them freaking Benadryl, but y'all can apparently.
So if you're super far away from the hospital, should you wait to get the EpiPen until it's like the last second? Because it only has 5 minutes, or should you just do it?
I would just do it if I'm like, they need an EpiPen, yeah. I would just do it. Again, those EpiPens, you can bust them open.
Is that why when they prescribe the EpiPens, there's usually 2 to 3 per pack?
Yeah. There's more than one. Yeah, EMTs can't give, even AEMTs can't give.
So silly.
Oh wait, no, AEMTs can't give.
It's so silly. You can literally buy it off the shelf.
Yeah, yeah, you can buy it off the shelf and carry it in your pocket, but as an EMT, you can't give it. As an AEMT, you can give it. Yeah, wow. But just remember, these are things that can come back to get you.
Hey,
So,
Becca,
a patient came in contact with an allergen or any kind of substance that's gonna cause, huh? Did
Can I
So that's
ask
why I'm gonna do advanced class 50. So.
Yeah, a basic is a great place to start for anything that you're gonna do medically, but AEMT is kind of like that.
Becca, can I ask you a question?
Have all the responsibilities of a paramedic. So any kind of contact with their substance, they have itching, hives, difficulty breathing, any signs of shock, low blood pressure, tachycardia. If their heart rate is higher than their systolic blood pressure number, you should be suspicious of shock. It's called a shock index. So you divide the systolic blood pressure by their heart rate, one or the other. If it's greater than 1, then they're in shock. The rule is if the easy way to do it is if their heart rate's faster than their blood pressure, their systolic blood pressure. That's a rule. So make it easy on yourself. That makes it greater than 1. All right, so as an EMT, your scope is to assist the patient. Again, this is coming to change. Follow your local protocol. So if you get trained on how to do epi, just do the epi. Make sure you check your expiration date. We're going to do our 5 rights of patient medication administration. So make sure the liquid's clear. Epi likes to turn like this ugly brown color when it starts to get expired. So make sure you're looking at it. It can also get little floaters in it. EpiPens, you can usually see, there's a little window that you can see the medicine in there. So remove the safety cap. See how this person put their thumb over that? And there's also the safety cap still on there. That's 2 no-nos. Okay, so don't put your thumb over the top. Because if you're doing it the wrong way on accident and you, ouchie. Yeah, big ouchie. So blue to the sky, orange to the guy. And the other ones look like a marker. It looks like you're writing on your patient. Use that, but just grab it like this. Make sure you remove the safety cap. Make sure you're not using a trainer. Usually whenever you get prescribed EpiPens, they send you home with a little trainer and they're like, train on this. Don't go stabbing yourself or the patient with the trainer. It's
Well,
not gonna do it.
typically it won't stab anyway.
It won't do anything. You just go in there punching your patient. Yeah, don't pull a Pulp Fiction, freaking go in their chest. Yeah. So
He's like, why not?
we don't. What's the optimal place to use the EpiPen? Like on the body, outer thigh. Yeah. So big muscle groups, we want somewhere that has a lot of vasculature, so it gets in the system quickly. The thing is, if somebody's in shock, they're gonna have a more difficult time getting it into their system because they're hypoperfused, right? So the bigger the muscle group, the better. The thing is, if you're gonna go on the leg, you can go through pants and stuff. Make sure they're not like super thick. They're not wearing like those big Carhartt overalls. You can go through like regular pants. The further back on their butt that you go, you have a nerve that runs down the back of your leg. Does anybody know what that is? Your sciatic, yeah. So if you freaking hit that sciatic nerve, that's gonna freaking suck. So just stay on the outer side of the thigh. You technically could do it in the butt, but stay on the thigh. You can do the upper arms as well. Again, that's not as big of a muscle group. It's gonna get absorbed faster in something like the thigh.
Look at me.
Are you looking at his arms?
I was like, man, there it is.
It's like big muscle.
Okay.
So hold it in place till the entire dose is injected. Again, that dose goes in pretty quick. So if they like pull away, you're probably okay. But try and hold it in place. Massage the area. Try and hold it there for 10 seconds. Massage the area for another 30 seconds to a minute. And then reassess. Anytime you do any kind of intervention, you should immediately reassess. Reassess after 2 minutes. It's not abnormal for their pulse rate to actually increase more if they were already tachycardic because epi is what? What's the other name? It's adrenaline, right? So when they gave it to me in the ER, my heart rate shot up to 160. I think I was chilling at like 120. And then it shot up to 160. I don't want to hear Mr. SVP. Okay? Okay? So pulse can increase, but do know that if you give it and you're subsiding their symptoms, there's a chance that their heart rate actually comes down if you're fixing the problem. So
Be careful whenever you do this with kids. Obviously, kids don't like being stabbed. So make sure you got a good grip on them. Make sure mom holds them real tight because you don't want to miss and pop yourself. So anytime you go to stick a needle, never stick your hand on the opposite side. So like even kids, you don't want to hold their leg and stab their leg on the other side. You want to hold it like lower and try to pop them just because if they move, then you pop yourself. So just keep that in mind.
So with the Epi, they have the Epi Junior and the Epi Adult. Can you give an Epi Adult to a child?
it's doubling the dose.
Yeah.
So you shouldn't in a like pinch when I do it. But for your textbook.
Or your local protocol.
Theirs, right? It should be theirs, yeah. So the dose, what's your dose in an adult EpiPen?
Like 3.
Good job. What's your dose in a kid EpiPen?
0.15.
Good job. Good job. What? 0.15 what? Milligrams. Good. It's important that you start saying like milligrams, micrograms, because once you like go further, it's very important because we give fentanyl in micrograms. If I was to give somebody 50 milligrams of fentanyl,
Super not crazy.
it's a lot of bagging and oh crap.
Don't person question what's the difference between a microgram and a milligram, like numbers.
Where the decibel is.
Yeah, where the decimal is. So you
So
move your
one like 0.10 and one's 0.1.
Yeah.
So one will be like 1, and then the other one would be like 0.001.
so you move it by 3.
3.
So
Great.
yeah, milligrams. If it's 10
10.
milligrams,
1.
3 this way. 1, 2, 3. So 0, 0, 0. So it'd be 10,000 micrograms. Whereas the other way, if you wanted to do it in grams, you go 3 this way. 1, 2, 3. So grams would be
0.01 grams.
yeah, 0.1 gram. So you move it by 3, your little decimal point. Does that make sense?
Yeah.
I kind of wrote it in gibberish.
So grams, milligrams, micrograms, every time you move over. So like magnesium, we give in grams. Most of our medications are given in milligrams, and fentanyl is given in micrograms. But if we're hanging drips of ketamine, which is normally given in milligrams, you do it in micrograms per kilogram per hour. So. Welcome to paramedics. That's what we do.
Because it's such a highly.
I'm trying to do that
drug,
for
but
2
it's
a.m.
such a small measurement.
Yeah.
Yeah, it's not me. Punch it in and it'll tell you.
Yeah. There's a whole, yeah.
Calculators on the phone.
I got calculators on the phone, I have cheat sheets, I have all sorts of stuff, because at 2 a.m. when I'm like, what's my epi drip calculation? How much do they weigh?
He has me.
I got him, yeah. I've been called out to like a 3-year-old seizing before, and I'm like, on the way to the call, I'm like, okay, 3, they need this much per set, but how much fluid do I pull up? And then I call him, like, is this right? He's like, yeah, about so. I'm like, okay, great. Yeah, he's my man. Right. Yeah. Okay, so you should have this down, right? So indications, anaphylaxis, right? Respiratory distress, history of anaphylaxis, severe asthma. So severe asthma is technically some kind of allergic reaction in their airway. So somebody that has asthma, they have certain triggers that make their asthma worse. Those are allergens, right? So if someone's having a severe asthma attack, and it's in your protocols to give epi, give the epi. If you're like giving them the breathing treatments, they're not turning around, they're really, really bad off. The trigger for me, if I put my stethoscope to their chest and it sounds like I'm listening to this wall right here and they're moving no air, they call it a silent chest, they're getting epi right away. So there's a possibility that your asthma turns into something like that. So don't be surprised. I was surprised the first time I seen like epi for asthma in a protocol. I'm like, I didn't learn this, but now you guys can't say that. All right, so it's a sympathomimetic. What does that mean? Good. It mimics your sympathetic nervous system. What's our sympathetic nervous system do? Fight or flight. Yeah, flight, freeze, fight, flight, freeze. So catecholamine, what does that mean?
What?
Catecholamine. This big word right here.
Ada. Mine.
I'm just kidding.
So it means that it's made in your body already. So we make epi ourselves, right? We have adrenaline from our adrenal glands. So it's a catecholamine. We have it already in our body. We're just giving more of it. So
Is that what mean means? Mine? Is it histamine the same?
oh, maybe.
Yeah.
That seems right.
Yeah.
What?
Let me put it on my board.
Antihistamine is
Make my little thing longer. I love it because that's why I like teaching, because I learn so many more things. It's
If
great.
that's really what it means, that would have to be.
Yeah, yeah. If it's mine, like I already have some.
Catecholamine.
So, non-selective alpha and beta receptor. So we learned about our alpha and beta receptors. Everybody remember the A, B, C, D thing, right? So it's non-selective. So it means that it works on alpha receptors and beta receptors. So does anybody remember what alpha does? Alpha constricts and beta dilates, right? So it's non-selective. It's going to work on both of those. So if somebody has wheezing, what receptors help with wheezing?
Beta 2.
Beta 2, good. If you have 2 lungs, very good. And then you have alpha. So if someone has low blood pressure, it's going to squeeze, right? So beta opens up your lungs, alpha constricts your vessels because everything lost their tone. So it's non-selective, so it's not going to be like, I'm just choosing alpha. We do have meds. You don't have to worry about them right now. We do have meds that are selective to like alpha receptors. You do have a med that's selective to beta 2 receptors. What is it?
Albuterol.
Good. Albuterol opens your airways, right? Good job. So, adverse effects. So tachycardia, palpitations. Again, it's epi. It's adrenaline. So it's going to cause your sympathetic nervous system to go off. So what's angina? It can cause chest pain. Very good. Very good. Cause a headache. What is this short for? Nausea, vomiting, diarrhea. So, nausea, vomiting, diarrhea. Again, your fight or flight, your gut's like, hey, I'm out. We got other things going on. And so it can cause nausea, vomiting, diarrhea. Hypertension. So it can make your blood pressure go up. Remember, if you have somebody that has really, really high blood pressure and they're in anaphylaxis, you can still give them epi. Even though it might cause their blood pressure to go up more, again, what's going to save their life? What's going to kill them first, right? The high blood pressure or the anaphylaxis?
So could you give someone a heart attack with the EpiPen?
You can. Well, not EpiPen, no. It takes a lot more. If you give them multiple EpiPens, yes. You can have what's called an epi-induced myocardial infarction. So,
Is that what you guys were talking about seeing it on the thing?
no, so anaphylaxis itself can cause like a stentomimic. Giving multiple doses of epi or really, really high doses of epi the wrong route. So like if I was to give it the EpiPen dose IV, it can cause a heart attack as well. It's just so much strain on your cardiovascular system. What's tremors? Sounds easy. What's tremors?
Shaking.
Yeah, cause you to shake. So precautions, use caution in pregnancy. If someone's pregnant and they're in anaphylaxis, they're getting epi either way. I don't care. Am I going to use caution? I'm going to be cautious about giving my epi. Sure. I don't know why they put that in there. I'm still going to give it.
Don't stop.
One for you, one for me. So contraindications, there is none in the presence of anaphylaxis. Again, if they're super hypertensive and they're in anaphylaxis, they're getting it. If their heart rate's super high and they're in anaphylaxis, they're still giving epi. You're still giving epi. So we've got the doses down. Up to 3 doses. If I want to give more than 3 doses per national registry, what do I need to do?
Call medical.
Call medical directory. All right, so epi, 3 to 5 minutes. It's half-life. It wears off after 3 to 5 minutes, no matter how it's given. If it's given in the IV, if it's given in IM, once it starts to work, it only works for about 3 to 5 minutes and then it goes away. So we continuously assess. We assessed everything, right? So what were they showing before I gave the epi and it went away? Is it coming back? You already know the call medical control. What questions do y'all have?
Can you
Yes.
put it in the bone? I know you probably should, but can you put it in someone's bone like IO epi?
Yeah.
Yes.
Anything you can do in a vein, you can do in a bone.
Go back.
Yeah. Go back.
Ooh, I'm gonna look at that video.
Is there any?
Ballot?
So as paramedics, right, or advanced teams, potentially us if it changes, right? What point would I do every like you know? Yeah.
Actually,
Yeah, he said EMT.
oh,
Yeah, no,
Oh.
you would.
yeah,
As an
you would.
AEMT, you can push cardiac epi like 1 to 10, which is just epi that I would do in a 10 cc syringe, milligram of epi in a 10 cc syringe, which is given in like cardiac arrest. So you get that 3 times, and work your cardiac arrest, like give it 3 times throughout the duration of about 20 minutes. Okay.
So the
And you can do
constant-
that IO, like just,
You
you
can,
can do
yeah.
that so that you can IO.
So your concentration of epi that you're giving is 1 to 1,000. So that you guys give. Yeah. So anaphylaxis epi,
Good.
no, go back or go
Sorry, for the puppy.
Do I use chat?
Yeah.
One more reason for the puppy.
So anything you give IV, you can give IO.
This is the concentration of the epi you guys give. It starts to get confusing when you're working on an ambulance and you're carrying multiple forms of epi because the code epi, the cardiac epi, someone's dead, we're pumping on their chest, that is 1 to 10,000. So if we're doing it in a vein, it is diluted, like it's concentrated, is a lot lower.
So Pulp Fiction is
Okay.
1, epinephrine is like
Yep, and it even gets more
like a
confusing
tenth of that. Yeah.
because we can also take epi and put it in a bag of like saline, and drip it, and it becomes 1 in 100,000.
Would you only do it in saline or would you do it in the lactated
You
drinker?
can do it in deep bags.
Okay.
Is it 100,000? His push goes in.
You take a milligram and put it in a bag.
Oh, I thought you said 1,000.
No,
A liter bag.
you can take 10 milligrams of epi and put it in a liter bag, make it 1 in 100. Take 1 milligram and put it in a 100 bag. And make it 1 in 100.
There's a lot of concentration. You need
You
to know
said
what
as
one goes in.
EMTs, we can't give Benadryl, right?
Correct.
So what if the patient has Benadryl and they automatically know, hey, epi's not working, I need to take Benadryl, whether.
If they have Benadryl, then you can
Let them, okay.
tell them.
That's just them to make it okay.
Like
Or
I told that
little-
I
mom
feel
to
like-
give her kids children's Tylenol.
Can you suggest it?
Yeah, absolutely. You're like, oh, this Benadryl fell out of my pocket. Don't do that.
Nah, no. Don't try to hammer through this one too.
How many slides?
40.
Okay, we're gonna. Anybody need to go pee? Huh?
Just take a minute.
Yeah, you go. I can take 5. Oh, take 5. Okay.
So, like, just need a
That's
minute.
what I was laughing in the beginning of that.
Okay, you can't phone me. Because they're gonna be flying you sacks.
Quick. Dude, I'm still on 20 on first. I know, I'm gonna get my phone. That was going through my head the whole time. Never were talking about it. Holy crap, dude. I can't. Oh, yeah.
So the amine and catecholamine, it just, it's related to the word amino. It's still yeah, it's still a good way to remember it.
Yeah.
So like amine, I think refers to the whole group of them. I can't remember. It was just weird. I was trying to look if there's like a Latin root because that's how I remember a lot of these words. Is you
Yeah.
just break it down.
I don't want to. No,
It says the neurohormones produced by the adrenal glands and nervous system. But I couldn't like connect catechol and amine to the adrenal system.
Yeah. If you see a cat, your heart rate goes up. Adrenaline.
There you go. But I like hers, mine, amine.
Oh yeah, I've seen that.
Yeah, no longer. Eyeballs no longer. It's a saying because if you have to go pee so bad that you're like, your eyeballs start floating. It's 7 o'clock.
It's all mass casualty bus accident.
I grabbed that one. That's that one.
How many slides was that last presentation?
20.
Yeah, if we hit 7:30, we can finish this up. We won't test on it, but we can finish the next class, just so we're not.
We're gonna try to get through these slides though, because me and Becca leave next week, so.
Yeah, we don't want y'all to.
Huh?
Really 40 minutes.
45.
So, from what I'm finding about the uterine contractions and anaphylaxis, they just did like a case study. A 35-year-old female, history of allergic rhinoconjunctivitis, so eye inflammation and like rhinos your nose. Without prior anaphylactic reaction, presented with a systemic reaction after 3 separate injections of a concentration. They were doing immunotherapy stuff. And her symptoms of anaphylaxis were nausea, vomiting, and she reported abdominal cramping that felt like uterine cramping. Isolated uterine cramping persisted despite the epi, so a 3rd dose of epi was administered, and 911 was called. And the epi fixed her uterine cramping eventually. So apparently they can be isolated to your uterus cramping.
But that case study is one.
That is one, right? And
Yeah,
that's the same thing as like the Narcan-induced pulmonary edema. Same thing. There's like when you read about it, there's like case studies with like 1 or 2 patients. So it's like so rare. Yeah.
It could have been just from being like tense up and.
So like, what were hormones doing?
Or like, you know, our referring to like what feels like it's hard to
Did you kill it? Oh, okay, I was like, that's not luck.
Is it a spider? No, it's not good. That's one had two. There was one in the toilet and one. Is he gonna try the toilet? Is he gonna do it?
No, do the thing.
Your name for your.
Either.
I don't feel things.
Oh.
And it's like, are you gonna get it? Kunis. Kunis.
So
I was doing it while you're.
I believe in that bad. Cartoon.
Huh? It's from what?
Syndrome. You said.
He's getting blood. Yeah.
Kunis.
No, I think that.
Oh, you did that? Yeah.
Like Mila?
So was it like it's stupid?
Mila Kunis?
This 31-year-old woman, pregnant, she's 30 weeks gestation, ate a strawberry-coated biscuit as a snack, and went into preterm labor. They treated her for anaphylaxis by administering antihistamines and epinephrine, and it stopped. She had a reaction to the strawberry-coated biscuit. Either way, it's rare, but
What's rare?
the uterine cramps and anaphylaxis.
We found 2 patients.
Yeah, there's like all the stuff is like, there's a case study of 1 female. Yeah, so, all right. It's been 6 minutes. I gave y'all 6 minutes. Again, if we hit 9:30.
9?
Or 7:30, sorry. I said 9 earlier. She said 9? No, 7:30. 7:30. We can finish it up next class. So we'll try and get through it, but. Okay. Yeah, you can do through Zoom, or if you miss it, you can like call us, figure out a day that a instructor is here, and you can just watch the video. They don't have to catch up then. All right, so objectives. Identify how diseases are spread. That's pretty cut and dry. It's gonna be simple. We know how diseases are spread. We all learn from playing the Oregon Trail, right? Don't drink this sweet water.
That's not yours, that's yours.
Yeah, don't die of dysentery. We're gonna learn the patho of sepsis. So what kind of shock is sepsis?
Distributed.
It is distributive, just like anaphylaxis, right? So they all fall under that umbrella. And then we're gonna review the most common infectious diseases. So infectious diseases are caused by bacteria, viruses, or other microbes. Prion diseases. Has anybody done any deep dive research into prions? Like Creutzfeldt-Jacobs disease, mad cow disease. It's terrifying.
Is that Mad Hatter disease too?
No, that's mercury poisoning.
I think, yeah, where you get like red as beef, dry as a bone, mad as a hatter, all that stuff.
What about that Lou Gehrig disease? that the same stuff?
No, that's more of like a it's like a muscle atrophy thing caused by eating stuff that you shouldn't be eating, but pretty sure Lou Gehrig's is caused by. So prion diseases are scary because it's like you have 100% mortality rate. So if you mad cow disease, like where you eat the brainstem of like somebody that's infected by this, you'll get it. And whenever you have surgery, if they suspect in humans, it's called Creutzfeldt-Jacobs disease or CJK something. They can't disinfect the surgery utensils. Like they have to destroy them with fire. So what it is it's like a prion disease. It gets in your brain and it literally just destroys you from the inside out. Usually they don't know like where the person contracted it. They usually can't even tell you if you've had it or not until after death. It's like one of those things that they find in an autopsy. They can suspect it, but they can't prove it until an autopsy. 100% mortality rate. There's nobody walking around that's like, I survived Creutzfeldt-Jacobs disease. So if you ever have a little bit of time, go down a deep dive of prion diseases if you want to freak yourself out. Super fun. I do it all the time.
Do you have to cremate that person to like transfer it?
I don't think so, because I know somebody whose dad, like they suspected that he had it, and they buried him like, so just don't go licking on people's brains. Don't go eat. Oh, there was like a big thing because it was getting transmitted in dog food because they were using like crushed up cows for it, and cows get it from eating like brain stems of other animals or like anything in this cerebral.
Is it the cannibalism play? Or is it
I think it might be the same thing. I don't know. Either way, it's terrifying. So communicable diseases means that it is a direct contact. You come in contact with secretions. If a little kid open mouth sneezes in your face and you get something, that's a communicable disease, right? If you go licking on the stretcher after you drop your patient off, communicable disease. Don't do that. That's yucky. Don't go swap and spit with people you don't need to be swap and spit with. Direct contact, communicable disease. So if Chad whips out his trauma shears, it gets ball blood in your eyeball. Communicable disease. Yuck. All right, so when do diseases spread? So there's like different phases of whenever you are like contagious, right? So there's usually like a dormant period where you don't really feel symptoms at all. It's still getting spread to other people. We learned this a lot. This should be drilled in your head if you paid any kind of attention to during COVID. Because they're like, oh, there's the dormant phase, and then everybody comes in contact with you, and then you get COVID, and everybody needs to get tested, and everybody's going to die, and it's horrible. So communicable period, it can be potentially transmitted. Just know that you don't have to be symptomatic for this period to be going on. So you could have like no signs or symptoms, but you're still spreading the disease. That's why we wash our hands. So, so that incubation period is what it's called. So that first little period, your incubation period, communicable period, and then like you actually develop signs and symptoms. That's why we wash our hands, right? Especially if we have kids that go to school or like anybody that's around with yeah. It's just every year they get sick in the springtime and in the fall. Yeah.
Put it in the air.
Yeah, cover your mouth. What are we learning about? Jeez. All right, so the virulence is the severity or harmfulness of the disease. So the dose, how much of that were you exposed to? So if a kid open mouth sneezes on your face, you were exposed to a lot of it.
That's fucking
Right.
gross.
It is fucking gross. Cover your mouth when you sneeze. It's nasty.
Is that real?
Kids don't have that though, like.
Yeah, kids just don't know. Yeah.
Kids are gross.
Like, is that like actual, like how much stuff comes out of you?
Oh, yeah, absolutely.
It's like 100.
It's a lot.
Look
Yeah.
up the Metallica singer, while he's singing, the show him doing that.
It's gross, so cover your mouth. Yeah.
The guy that tested me for COVID, he stuck that thing up my nose and it just, I could see it all over his face shield. I was like, well, that's a good thing. Did you sneeze, did it?
Well, it's his fault. He shouldn't be sticking stuff up your nose.
Yeah.
All right, and then your body's resistant. So we have immune systems for a reason. If you recently contracted like the cold, chances are you're not going to get it immediately after. Not saying that it's not going to happen, but you build up an immunity to that. So what's your immunity to this? Vaccines give you an immunity to certain things. It can make it like less severe because your immune system's already trying to fight it off. Sepsis. This is going to get drilled into your brain, and every patient that you have from here on out, you're going to have a little guy that's sitting on this shoulder that's like, is it sepsis? And then there's going to be a little guy sitting on this shoulder that says, is it anaphylaxis? Because that's what should be going through your head. So sepsis, big thing, kills a lot of people. Early recognition is key to survival for anybody that has sepsis or suspected sepsis. So to put into perspective, we give a sepsis alert. There's a sepsis team. Like if you go to any big hospital, they have a whole sepsis team that shows up and is like, okay, and they look like a little pit crew. They start drawing blood. They start hanging fluids. They start hanging antibiotics. It's one of those things you want to catch really early. So if you guys can catch it early in the field, it is huge that you're like, hey, sepsis alert. Not so much here because this is a Band-Aid station. But if you're working in any kind of bigger hospital, they can get these things going, which is really important. So, life-threatening condition, if it is untreated, it turns into something called MODS, which is multi-system organ dysfunction failure. Basically, your organs start to shut down. Turns into a really bad day for everybody. Where do you think sepsis can start?
Your blood.
Anywhere. It goes to your blood. It can start anywhere. It could be an infected.
Right?
Huh?
Or an infection.
Technically, yeah, any kind of open wound, right? But if I have if I get pancreatitis, that's not open. But that pancreatitis, like inflammation of my pancreas, it can cause sepsis as well. So it can literally start from anywhere. Females, very susceptible to UTIs. UTIs cause sepsis all of the time. So it's an infection that has gone untreated and now it has gone to their whole bloodstream, right? So sepsis, bad day. So if you have a tooth that you're like, this hurts, but I don't want to go to a dentist, and it starts to get all swollen up, and then everything starts to turn red, and you start running fevers, you start getting really dizzy, you walk into the hospital, and they're like, oh yeah, you should have came in 2 weeks ago. Sepsis. So, abnormal counterproductive response to the body. The infection is causing damage to the tissues and organs. Remember, shock is hypoperfusion, right? So, septic shock is causing hypoperfusion to your organs and all that jazz. So, the other thing about sepsis is your cells and all your vessels also get leaky, like it would in anaphylaxis. It's just a different pathophysiology of how it gets there. So, still a distributive shock, just comes from two different kinds of sources in your body. So, whenever they start to go into a shock state, they get hypotensive, and their body stops responding to IV fluids. We have medicine that can make their blood pressure go up, hopefully. We hope that works. But for example, we went out on a guy a few weekends ago. He wasn't feeling good that weekend. His family came and checked on him, told him that he could wait till Monday. Wife decided to call us. We got there, he was out of it. He wasn't completely altered, but he was clearly not having a good time. His blood pressure was 140s over 70s initially. By the time that we flew him out 4 hours later, his blood pressure, he was on a levofedrip, so something for his blood pressure, and it was still only 90 over 40. So it only took that amount of time for him to freaking tank and things to start going really south. Now, if he would have waited till Monday, we would have been all attending a funeral. So these are things that you want to catch early. So that infection starts locally, wherever locally is. So it's the pancreas, pancreatitis, it's a tooth, it could be an ear infection, it could be something like diverticulitis, it could be something like a UTI. It starts local, it starts in one spot. So increase of white blood cells are leukocytes, right? White blood cells, they help us fight our infection. They start to get overwhelmed. The body produces lactic acid. The problem with it producing lactic acid like that is our body has a very happy pH, right? We like to sit at 7.35 to 7.45. And lactic acid is an acid, so it makes you more acidotic. So as you get this lactic acid buildup, your body gets out of its happy little pH range. Well, whenever your body gets out of its happy little pH range, your systems start failing. That's all of our cellular functions need to be done in a certain pH. So once that pH, we become acidotic, our body starts to shut down and stop working. White blood cells, they can be limited or exhausted. So once you hit a certain number of white blood cell counts, it's only going to do so much for you. If that's overwhelming the system, your body can keep producing white blood cells, but those white blood cells aren't as effective as they were if you would have caught it like earlier as they were in the early stages of this. So as that acid accumulates in the bloodstream, those vessels start to dilate, they start to get really leaky. So increased permeability is what that's called. They just get leaky, and then it can lead to hypotension. So low blood pressure, right? We know shock, low blood pressure, high heart rate, right? Where sepsis changes a little bit because you start to get like the fevers, other kinds of signs. So I'll show you what to look for. Here's just a visual representation of that last slide. So whenever you let it get to this point, it's a problem. So sepsis and infection in particular likes to come in and settle on your heart valves. So you can have a lot of problems like heart problems, heart failure from sepsis because that infection likes to come in and hang out right on your little heart valves. It causes a lot of problems in the heart, causes a lot of problems in the lungs. Because our lungs are what blow off acid, right? So if our pH is messed up, our lungs try to fix it by breathing faster. And if you just have too much of a buildup, your lungs are going to start to get tired and they get affected as well. Does that make sense? There's a lot of things that are kind of coming together now, right? So locations that are likely to be associated with sepsis. So our lungs, what kind of big thing do you think happens in our lungs that can cause sepsis? Pneumonia is a big one, right? So we see that a lot. Now, if you're ever like suspecting sepsis and you can't really pinpoint what's causing it, you still need to call a sepsis alert. If you're like, well, their lung sounds are clear and their skin's fine, and, you know, they didn't have diarrhea or they don't smell like a UTI, they don't have UTI symptoms, you still need to call the sepsis alert. You do not need to pinpoint where that sepsis is coming from. So like our guy that we took the other day, even the doctor that flew him out couldn't pinpoint his infection. He had to send him out for further testing. He suspected that it was from like some tooth work that he had done and the infection had gone to his heart and now like they couldn't do the echo or whatever. But still even the doctor couldn't pinpoint it, but it was like, yeah, he's septic. So lungs, you got your pneumonia. GI tract, so any kind of abdominal surgery, obviously, any kind you cut someone open, it can be a source of infection. Pancreatitis is a big one. See that a lot in like diabetics or pre-diabetics. That can cause a lot of problems. The GI tract, so I can never say this word, the genitourinary. So this is like your kidney, prostate infections. Urinary catheters, if somebody has a catheter, like a Foley catheter in place, or if they straight cath themselves. So there's a possibility that your patient has to, they call it straight cathing. What it is they take their own catheter. Every time they pee, they go to the bathroom, they put the catheter in, they pee, and then they toss that or keep it, disinfect it, whatever they're going to do. Again, you're entering a foreign substance into your body, so it can be a source of infection. So
is that normal? Like, are people prescribed to do that?
Yeah, so the big one is, what's the word I'm looking for? The thing where they're born with the spine on the, with their spinal cord outside of their body.
Oh, wow, spicy.
What's that called? I keep wanting to say cystic fibrosis, and that is not it. Spina bifida. Yeah, so spina bifida can cause like complete paralysis of just your bladder. And so a lot of times, like people with spina bifida, if they are able to do other things and just their bladder is paralyzed, they'll straight cat themselves.
You know that patient.
I think I know that.
Patient.
Yikes.
Yeah, like you
They
know
actually
what?
needed them?
Huh?
They actually needed them, or they just
No,
decided they
That's a
wanted?
freaking.
Now, there's something called Munchausen's,
Oh,
and I believe this patient has it. Yeah.
Didn't I dream it all? There's like 3 kinds of spinal damage, sorry.
I think so, because there's like one where it's like there's like spinal like stuff is completely outside, but then there's some of it that's not. Like
Yeah,
there's
'cause I was never, my back's all messed up, and I was told that I have that, but it's just, it's not fully formed on the bottom.
usually it's like right
So
here.
my nerve's still inside of my, it's not the outside.
Did they say call it like Cauda equina syndrome or something?
I'm not sure, she just said that it sucks. and
Yeah.
it'll help you with the whole life.
Yeah,
The
it does.
doctor's like, damn, Dean, that sucks.
Yeah, I have to get epidural injections like once a year.
Okay, so skin, so gastrostomy tube, blah, blah, blah. So tubes, G tubes, J tubes, tracheostomies, right? Long-term catheters. Whenever they're long-term stay in the hospital, they change out the catheters like every 3 days. Pressure sores. If you have a patient that's been sitting in one spot for a long time and they start to get that pressure sore, sepsis. Cellulitis is a big one. So somebody, usually it's like your drug abusers can get it. Somebody that doesn't have that like long-term like swelling of their legs, you'll start to see like redness on their legs, or like along their arms and stuff. So cellulitis, infection of the skin. So our criteria, they're kind of moving away from this and they're going to a new criteria called Q-SOFA. They're literally almost the same thing except for the FEEP. That's the only difference. So anytime you see 2 of these 3 things, you need to be on high suspicion of sepsis and you need to be treating for sepsis or letting somebody know. So you can have something that they used to call cold sepsis. I don't know what they call it now. I still call it cold sepsis. So you don't have to have a fever, but if they have a low body temperature, that's like a late stage of sepsis. So if you're to that point, it's not looking good for your patient. A high, anything higher than 101. So your fever. If their heart rate is greater than 90, that includes 92. So even though 92 is not tachycardic, if you're just sitting there and they're resting at like 92 and they have a fever, that is 2 of these 3 things. So that's your sepsis. Respiratory rate greater than 20, so their respiratory rate goes up. Again, if their heart rate was 92 and the respiratory rate was 24, and I'm suspicious of sepsis, I would be calling a sepsis alert. And then a systolic blood pressure of less than 90, and I think there's one more. New onset of altered mental status or worsened mental status. Now, what kind of demographic do you think has like a higher sepsis rate?
Children and elderly.
Mostly the elderly. Kids can get it. Kids are really good at compensating for like infections. The big one is like anybody that lives in a nursing home. So there's some criteria out there that if you pick them up at a nursing home, they automatically meet one of the criteria for sepsis. So just depending on like your protocols, but nursing homes are a big one. And if anybody's ever been in a nursing home, I'm going to exclude this one. This is actually a very decent nursing home, one of the best I've ever seen. But if you walk into a nursing home and you smell that urine, like you know what a nursing home smells. You can smell UTIs all over the place. If you ever want UTI exposure therapy, walk into a nursing home. Yeah, walk into a nursing home in any kind of city. The one in Elko meets that criteria. So this one's not bad at all. They do a really good job over here. It's quite impressive, actually. And the fact that they attach it to the hospital, like,
Makes our life so much
yeah,
easier.
so much easier. If you work outside of any place that has their nursing home outside of a hospital, that is the majority of your call line.
I think they're not putting another one in.
I heard that.
Assisted living.
Hopefully they just like put a tunnel to the hospital.
Yeah, they can just wheel them. Yeah. All right, so if your patient meets SIRS criteria, inform the receiving hospital by calling a sepsis alert. Out here, again, it's not that big of a deal. Once you start working around bigger cities and stuff, call in and say, hey, first thing out of your mouth, this is Becca with unit whatever. I'm calling in a sepsis alert. That should be the first thing out of your mouth. And then any kind of sepsis in an infected patient, you might get that patient that their toes are completely black, but they don't meet any of your criteria for sepsis. Oh yeah. There's a dude that was walking around Atlanta. He got in a car accident. His bone was sticking out of his leg for like months. And his toes were black and his bone was hanging out. And he just refused to go to the hospital.
Yeah, they like took him to the hospital, he left AMA. Just never got it taken care of.
Mhm. All right. So this is our last slide. We'll finish this up on our next thing. But this is that other criteria that we were talking about that's kind of coming into fruition. This is called QSOFA. So depending on where you work is going to be what criteria they use, what hospital they're working with, and what criteria they use. Again, greater than 2 of these symptoms, a lot of the same stuff. Systolic blood pressure less than 100, where that changes from the SIRS is 90. So systolic blood pressure less than 100. If their GCS is less than 13, I freaking hate that they threw GCS in this. Altered mental status. If they have altered mental status, that is
Outside
no
of their
onset.
Right,
Outside
just like we said, dementia patients can have a altered GCS if it's more altered than what their normal is. Does that make sense?
And then tachypnea. So if the respiratory rate is greater than 22, any 2 of these, it is a sepsis alert. And then if they use this a lot in the ICUs to predict whether they're going to make it out of the ICU or not. So if they meet this criteria, their likelihood of survival goes like lower and lower.
So that's what, like on the slide on the computer, it says does not predict whether someone is septic, it just predicts how long they stay. Is that, I mean,
So it used to be that. It was more like the ICU thing. And just recently we were talking with Calvin about it. They're coming out with like, QSOFA is good for pre-hospital stuff too. So like your book's so tiny that like medicines takes forever to catch up, right?
right.
So again, I would go off of what your textbook says if you ever see it. But just know that like as you start practicing and you're starting to do like further education and you start seeing this stuff coming around, it's not gonna throw you completely.
So they are starting to use this to actually predict whether someone has sepsis?
Yeah.
It's more of just like an alert than a prediction thing,
Yeah.
because it's
Do they?
so all it is like an alert process, right? So if you go inside the hospital, they have an alert process where they have anybody that flags for sepsis, they're supposed to have like blood cultures and all this stuff done within like the first so many minutes of the patient walking into their ED. So this is their way of like alert, we need to do this. So when we walk into the ED with like a sepsis alert, especially one that fits these criteria, then that's their alert. And a lot of times they'll like meet you, in the triage area, or they'll have you go straight to a room. That way they can start pulling labs and stuff. Because they want labs drawn, cultures back, and medications to be administered within like the first 30 minutes of them being in the ER. I think it's 30
minutes.
minutes.
Yeah, they want like antibiotics hung, like fluids running, like they give sepsis patients huge amounts of fluid, like up to 3 liters. So 3 big bags of fluid, they'll do 3 of those. That's a lot of the criteria. As soon as they walk in, if they meet 2 of these, they're like, here you go.
This is like legitimately probably one of the only patients that you'll see like bilateral IVs and just bags of fluids just pushing. Because we're supposed to, even at pre-hospital setting, like we should be giving like 2 liters of fluids within the first like 30 minutes to an hour of us making contact with them. So it's very excessive amounts of fluids.
Why were his toes black?
Because he wasn't getting no blood flow to them anymore. Like everything was cut off.
They were rotted.
Yeah, infectious, rotting.
They'll die.
It's not common. There's a.
That's what I was thinking, but I'm like, it's not.
Do I use what?
Mm.
So maybe this is a dumb question, but is sepsis technically contagious? Like, let's say you have a cut and you come into contact with.
Something that calls sepsis could possibly, like if you're septic secondary to like pneumonia.
Infection itself would be contagious, but not contagious. Sepsis is just that it's spread. It's spread. Okay.
Yeah, it's not like, you like accidentally poke yourself with a septic needle. You're gonna get
It's not an
sepsis.
infection itself, it's
Their body's response to that. Yeah.
Yeah, so like certain, like if you get like really bad flu that leads to like pneumonia, that leads to like sepsis, you can catch that flu.
Right.
But like sepsis in and of itself isn't something that
It's
you're.
not contagious.
Because all it is bacterial infection.
okay.
Does that make sense?
Yeah.
I don't know what tegument is. I just Googled it and it said outer covering. I'm gonna text her.
So
All right, so while we're going, so we'll teach tonight, we'll teach Tuesday, we leave on Thursday, be on the airplane. Y'all agree? No, we're leaving. If y'all need anything, y'all can still reach out to one of us. We'll still be able to be in contact. But